Now, as the chairperson has rightly pointed out, the role of inflammation in diabetes. We know that all these diabetes, cardiovascular disease are inflammatory diseases. And how does it impact the inflammation? How does it impact in the pathogenesis and the treatment of the diabetes? Now, if you look at the insulin molecule, how does insulin act? And how the inflammatory markers target the insulin receptors? Whatever may be the microbial products, lipids, fatty acids, chemokines, and pro-inflammatory, ultimately these act on the insulin receptors like toll-like receptors or RAGE receptors. And what happens inside the cells, it acts on the Janus kinase and nuclear factor kappa B, which is a master switch. This is an inflammatory gene. Once nuclear factor kappa B is activated, various inflammatory genes are activated. Now what happens? If we look at the adipose tissue, it is infiltrated by macrophage. If you look at a skeletal muscle, macrophage is there. And various liver macrophage is there. Now macrophage, they release various cytokines and chemokines which cause the inflammation, which cause the insulin resistance, act on the beta cells and hypothalamic inflammation. Now this is the beta cells. These are normal beta cells. And if you see, this is the beta cells in the diabetic patient, which has been infiltrated by the macrophage. And this is the CD68 positivity, which means that beta cells in diabetic is infiltrated. That means there's an islet inflammation is there. And this happens the hypothalamic inflammation. Same inflammatory markers act on the hypothalamus, act on the POMC, FOXO1, neuropeptide white. As a result, diabetic patients, they tend to eat more. So there's an inflammation at the receptor level, insulin receptor level, beta cell level, and hypothalamic inflammation. So widespread subclinical inflammation is going on in a diabetic patients. So what are the potential targets? Now, targets can be cytokines, lymphotoxins, transcription factors, receptors and surface proteins, or others. Not only inflammation is involved in the pathogenesis of diabetics, but in diabetic complications also. Like there are numerous papers to show that cytokines and cytokine-like inflammatory markers are increased in various diabetic complications, immune mediators in patients with acute diabetic foot syndrome, role of inflammatory cytokines in diabetic nephropathy, and inflammation in the diabetic retinopathy. So how do we target inflammation? Earliest mention was of that willow for its analgesic and anti-inflammatory, antipyretic properties somewhere in 1500 to 2000 BC. And interest was revived somewhere in 18th to 19th centuries regarding use of willow bark. And active extract is salicin. 38, Riefel, Italian chemist, isolated more potent salicylic acid. And 1897, Hoffman created synthetic version, what we use as aspirin today. Now, aspirin, as you know, is a potent anti-inflammatory, but it has a problem with these GI problems, renal toxicity, and bleeding problems. So, salicylate is non-acid-related version of salicylic acid. As a result, GI side effects, renal side effects, and bleeding tendencies are not there, but anti-inflammatory properties are retained. So, this was the first published paper in 1901 in BMJ, where salicylates were used to treat diabetes. Then subsequently, there have been a lot of publications, and this was a Tinsel 2D publication, placebo-controlled, randomized controlled tried in the patients 18 to 75 years, fasting plasma glucose somewhere less than 225, HbA1c 7 to 9.5. And after 4 weeks of intervention, where salicylates were used in gradually increasing dose 3, 3.5, and 4, it was seen that there was a HbA1c reduction of around 0.5%. Why? There was a decrease in adiponectin, and the drug overall was well tolerated. So one can appreciate decrease in HbA1c. This was with 3, 3.5, and 4. As we increase the dose, more HbA1c reduction was there. This was another double-blind placebo-controlled trial. This was in the obese young adults who are not diabetics. So what was seen that there was a decrease in fasting plasma glucose. However, PPG sugar was not affected. And this was a decrease in HbA1c. And one can appreciate decrease in adiponectin, CRP, and free fatty acids. Another study, 286 patients where salicylates were used, and again one can appreciate decrease in HbA1c was seen. At 48 weeks, mean difference between HbA1c patients who were given salicylate and placebo was around 0.37%, and significant and comparable to other drugs. Lower leukocytic count, neutrophilic count, and lymphocytic counts were seen. Adiponectin increase. We know that adiponectin is an anti-inflammatory cytokine. But there was a 6-fold increase in relative risk of mild hypoglycemias, and there was a 1.3 kg weight gain, which was probably due to hypoglycemia, but concern was mild increase in LDL. Tinnitus was also there. As we know, we increase the dose of aspirin, tinnitus is there. Again, area of concern was that there was a mild increase in urinary albumin concentration and mild decrease in GFR. So long-term studies are required to assess really whether it affects the diabetic nephropathy or natural course of GFR. Mild GI symptoms were seen in terms of the mild bleeding, GIT bleeding. Now, salicylates has action. How does it act? It basically, as I told you initially, nuclear factor kappa B is a master switch of inflammation. It decreases that. Besides that, it decreases AMPK, increases AMPK activity. And I will come to this AMPK activity later on also, because this is a particular, this molecule transcription factor, which can be increased by some ordinary means which are often neglected. And then it has an effect on the liver also, decreases hepatic glucose output. Then effect of salicylate, this was another study to show that there is an increase in fasting plasma glucose. Now, another cytokine is interleukin 1b. We know that interleukin 1b is implicated in so many inflammatory disorders. And in beta cells, it causes the beta cell apoptosis. Now, what about targeting interleukin 1b? One can see this is a diabetic, this is the control, and this is a diabetic patient. Interleukin 1b expression is increased. That means it causes the later on apoptosis of the beta cells. So what about targeting interleukin 1b? This was a study which was published in NEJM. This was about 34 patients received 100 milligram of anakinra, which is given subcutaneously. It targets the interleukin 1b receptors. And at 13 weeks, HbA1c decreased by 0.46% as compared to the placebo, and C-peptide secretion was enhanced. And one can appreciate decrease in HbA1c and decrease in fasting plasma glucose. And these are pro-insulin to insulin ratios. This is area under curve for C-peptide after IV glucose, and this is area under curve for C-peptide after oral glucose, and this is area under curve for C-peptide after oral and IV glucose combined. So all parameters improved. This is to show that decrease in inflammatory markers, C-reactive protein and interleukin 6. So by giving anakinra for about 13 weeks, there was an improvement in C-peptide, pro-insulin to insulin ratio, and decrease in HbA1c. And follow-up of study after 39 weeks revealed that there was an improvement of pro-insulin to insulin ratio, but not stimulated C-peptide. A subgroup in that patient showed that patients who had a low baseline interleukin levels maintained improved stimulated C-peptides. There is another study to targeting another molecule, targeting interleukin 1b receptor with Juvacozumab. Now in this trial, what was given that in the various escalating doses, it was used 0.03 milligram to 0.1 milligram per kg body weight, and improvement in HbA1c was seen. What about targeting TNF-alpha? We know that TNF-alpha is implicated in rheumatoid arthritis and so many inflammatory disorders. Targeting it by infliximab, it was seen that whatever you target TNF-alpha, improvement in the glycemic profiles was not seen. Statins. We know that statin has got an anti-inflammatory activity. And statins decreases all MCPK1 and nuclear factor kappa B also. And rosuvastatin in this Meteor studies was seen that there are 36% decrease in C-reactive protein. But we know that with statins, there is a 12% increase in the new onset of diabetes. However, cardiovascular diseases are decreased. In spite of its anti-inflammatory action, this incidence of new onset of diabetes is increased. So there are a lot of gray areas which inflammatory targets to be targeted to decrease the HbA1c, whereas statins increase the HbA1c. What about steroids? We know as of now steroids are the most potent anti-inflammatory drugs, but with the steroids, we know that it decreases IRS1, IRS2, and look at this, glucose disposal measured by euglycemic hyperinsulinemic clamp. It is decreased, and it increases the hepatic glucose output. You give a steroids, methylprednisolone to most of your patients, you see the rise in the blood sugar. So in spite of its anti-inflammatory effect, there is an increase in the plasma glucose. So we ought to know which are the inflammatory targets which should be targeted to decrease the plasma glucose levels. This is another slide to show a ratio diet. Now, if diet is rich in Omega-3 fatty acid, it has got anti-inflammatory activity vis-a-vis if it is rich in omega-6 fatty acids. These are some of the other anti-inflammatory drugs like berberine, which is present in plant extracts, then myrcene, which is a natural flavonol, then heme therapy to improve HbA1c by its anti-inflammatory effect. Now, potential new targets are histone deacetylase inhibitors, 12-lipoxygenase inhibitors, activation of sirtuin, and gut microbiota. Mark my words, next decade is going to be the decades of gut microbes. A lot of therapies are going to come which will target the gut microbes to improve the gut microflora to decrease the inflammation. What about the new drugs, day-to-day drugs which we use in our practice? About the sitagliptin. Sitagliptin, one can see there is a decrease in the inflammatory markers, CRP, interleukin-6, and TNF-alpha. So is with the rosiglitazone, which increases the inflammatory markers. This is a slide which I initially mentioned about activating AMP kinase. Now look at the lifestyle, metformin, placebo. With the lifestyle, there is the improvement in all the inflammatory markers. Please insist in your day-to-day management to your patient, the lifestyle is the core in the treatment of diabetes. It decreases the inflammatory markers and improves so many profiles, which I will discuss in next slide. Now, if we look at the inflammatory markers, what we are targeting is at this level, or at this level. But our targets should be at this level. Now, before the inflammation has started, that is a lifestyle. Nothing can be done about the age, but yes, fetal and neonatal metabolic programming can be done, and genetics and race, nothing can be done. So two aspects which can be tackled before actually inflammation has started is the lifestyle and fetal and neonatal metabolic programming. So what does that mean? That means at the preconception level, mother should be euglycemic, take good care of mother during antenatal care so that fetal programming occurs in a better manner, diet, exercise, and avoiding stress, so that children are born by normal vaginal delivery instead of cesarean delivery, because that microbes exposure is something different. Allow your children to play in plenty of sunshine, they develop good muscles, lot of vitamin D, and by exercise, what happens? There is AMPK kinase activation, so decreasing inflammation, less stress, and avoid gain in weight, because that is adipose tissue is a highly inflammable tissue, lot of macrophages are there. So if you look at the various drugs which are used in the treatment of diabetes, targeting weight, insulin sensitivity, lipids, hypertension, endothelium, inflammatory markers. Only therapy which targets everything is lifestyle, exercise. So that is the importance of exercise in the management of diabetes. So I feel, besides whatever molecules I have discussed, good takeaway home message for this audience would be anti-inflammatory therapy should be in terms of eat less, eat healthy diet, walk more, so that AMPK is activated, smile maximally, so that hypothalamic inflammation is less. Believe me, by smiling, all your control-regulatory hormones go down and inflammation decreases. So ladies and gentlemen, inflammation is involved in the pathogenesis and complication of diabetes. We have to target various molecules, but as of now, we don't know at which level of the inflammation, which targets should be targeted to decrease HbA1c. We have various studies to show that salicylates are good in terms of decreasing HbA1c and improving beta cell function. The oral hypoglycemic agents which we have right now, like sitagliptin, glitazones, and metformin, have good anti-inflammatory activity. Newer targets are being targeted, and again, lifestyle management remains the core in the treatment of diabetes, and it is a good anti-inflammatory agent. And thank you, ladies and gentlemen, for your patient hearing. And I sign off with this image: ponder over and act upon. Thank you.